Welcome to the Virginia Hospital and Healthcare Association's Patients Come First podcast series. Podcast episodes are available on VHHA.com and on popular podcast hosting apps including Apple Podcast, Amazon, Spotify, and many others. We're a member of the Public Health Podcast Network, Virginia Audio Collective, and the World Podcast Network. Podcast episodes also air Sundays at noon on 100.5 FM, 92.7 FM, and 8:20 a.m. across Central Virginia, 1650 a.m. in Hampton Roads, 105.1 FM, and 10:50 a.m. in Lynchburg, and Wednesdays at 1 p.m. on 93.9 FM in Richmond. Please send questions, comments, or guest suggestions to pcfpodcast@vhha.com. That's pcfpodcast@vhha.com. Today, we're excited to be joined by Dr. Keyur Shah, Chief of Advanced Heart Failure at the VCU Health Poly Heart Center. Dr. Shah joins us for a conversation about his career working with heart failure patients, the VCU Health experience with life-saving left ventricular assist devices, and more. With that, welcome to the show, Dr. Shah. Thanks for being with us.
Thank you so much for having me.
We like to uncork these conversations by letting our guests share a bit about themselves. What we know, Dr. Shah, and we mentioned, is that you are Chief of Advanced Heart Failure at the VCU Health Poly Heart Center, which you joined in 2009 following undergrad at UVA, medical school at the University of Pittsburgh, and residency, internship, and fellowship at the University of Maryland Medical System, among other stops. Dr. Shah is also a clinical researcher and a fan of the often lowly but more recently relevant Detroit Lions football team. Beyond those few details, what should people know about your unique personal story?
Yeah, well, thank you for the introduction. And yes, I'm a Virginia and Richmond native, so coming back to VCU and MCV was a welcome opportunity after I finished the long road through fellowship. And I'm happy to be here, having been here in Richmond as a professional for the last 15 years. And I think many of the audience may know what my subspecialty does. It's a relatively new subspecialty. Advanced heart failure and transplantation is a field that's existed for ages, but the treatments for it have become more and more subspecialized and require additional training. And so now it takes an additional fellowship after cardiology to practice in this field. So we are cardiologists, but we're cardiologists just like interventional cardiologists or EP cardiologists who have a niche to care for patients with heart muscle disease.
And that ties directly into my next question, and you touched on it a bit, but tell us a bit more about your work, if you would. In your role as Chief of Advanced Heart Failure and Medical Director for the Mechanical Circulatory Support Program and the Heart Failure Navigator Program, what is a typical day like for you?
Absolutely. Well, it is sometimes unpredictable, and I care for a broad spectrum of patients and work with a variety of programs aimed at ambulatory patient care, in-hospital patient care, and quality improvement. So if we start with the types of patients I see, which I think most people can relate to, is myself and my partners, we take care of patients who have usually dysfunction or weakening of the heart. And this comes in many different flavors and causes. Unlike 20, 30 years ago, where we attributed most heart disease to either coronary blockages or heart attacks or high blood pressure, we've become much better at identifying deeper phenotypes or causes of heart disease, including other systemic illnesses that may contribute, like thyroid disease or inflammatory conditions, or diseases that run in family, like hereditary cardiomyopathies. Also, valvular disease or pericardial disease, and stiffening of the heart associated with aging or metabolic syndromes. Because of all this subspecialization and different treatments for each of these groups, one of the first things we do in consultation for patients is try to identify the cause of their heart muscles. So the spectrum of patients that we see include those at risk for heart failure and then those at the very late stages who may require advanced therapies. And this is where our extra training really comes in handy. It's at this stage of patient care and management we talk about things such as heart transplantation or palliative care and hospice in patients who are at end-stage disease without options. And in some patients who may be candidates, we even talk about mechanical heart pumps. And the most commonly used durable mechanical heart pump is the left ventricular assist device. It's in this role, and running this program, I'm the director of mechanical circulatory support. In addition to patient care and caring for the spectrum of heart failure, the job of a heart failure cardiologist also involves partnering with a hospital to address quality of heart failure care delivery. Heart failure is the most common diagnosis for heart hospitalization in the United States, and it is a burden on costs and occupation of hospital beds. It's along this lines we work with hospital units, other providers, and administration to develop programs to help care for these patients to try to reduce time in the hospital and the burden and cost to our healthcare system. These include programs to ensure that providers are implementing guideline-directed therapies, that patients have access to clinical care after hospital discharge, and that there's a smooth, clean transition from the inpatient to outpatient side. Part of my time also involves ensuring we have innovative programs, keeping up to speed with evolving technologies and care delivery models to make sure patients in Central Virginia are getting top-notch heart failure care.
Let's talk about heart health and heart failure. Statistics show that heart disease is the leading cause of death among men and women across many racial and ethnic groups. It is responsible for roughly 1 in 5 U.S. deaths annually, and by 2050 it is estimated that 6 in 10 U.S. adults will have some form of cardiovascular disease. Heart failure is a condition in which the heart is not capable of adequately supplying the body with blood. It has 4 stages, with the final 2 stages signifying symptomatic and functional problems. As a baseline for the rest of this conversation, can you give us an overview of heart failure, how it impacts patients, and how it can be medically managed?
Absolutely. So that was a very well-structured question that plays into the answer here. Heart failure is the condition where the heart cannot supply adequate blood circulation, and there could be a congestive component to it where blood backs up into the lungs and then other vital organs. So when the heart is actually failing, it's usually not an abrupt condition, but one acquired over time. And as the heart weakens and the blood delivery is compromised, patients start developing symptoms of fatigue, shortness of breath, lack of energy, change in appetite. They may, on exam, have signs such as swelling in their legs, distension in their bellies and abdomen as they fill up with fluid. They may have to take medications that make them diurese or urinate to get rid of fluid. Overall, as the disease persists, it gradually becomes more severe. And in the later stages, patients can have compromised function of their kidneys or liver. They can end up developing muscle wasting. They can also eventually have low blood pressure, poor perfusion to their brains, and deadly arrhythmias. Much of this occurs over years. In the last several decades, there have been many breakthroughs in treating these conditions, including the evolution of medications which stave off some of these later symptoms and improve quality of life and survival. Along that lines, there are things patients and patients' families can do to help prevent later stage heart failure. And many of those we've heard over the years still remain true, including eating a healthy diet, maintaining a normal blood pressure, avoiding smoking, avoiding abuse of toxins beyond acceptable levels such as alcohol. And then there's some things that we don't control and we are better understanding, including our genetics and our DNA, and also congenital deformities that we might be born with. All of that being said, it's an exciting time in that there's therapies and better understanding for causes of heart failure, and the treatments are evolving for the entire spectrum, ranging from preventing heart failure to treating the very late stages.
One of the medical interventions available to patients when it is medically indicated is a surgical procedure to implant a left ventricular assist device, which can help the heart pump blood to maintain consistent flow. VCU Health recently completed its 100th HeartMate 3 LVAD procedure. Can you share your insight about how LVADs work in patients who may be candidates for that device?
Yes, thanks for that question. So VCU did complete its 100th or so HeartMate 3 implant, and before that, there were several hundreds of other VADs implanted too. The ventricular assist device, the durable types, have been implanted for over 20 years here and across the country. Now, the type of patient who we'd consider for an LVAD is someone we've exhausted all other options on, and still the patient fails to improve in their heart failure. So, for example, it's someone we've tried medications, pacemakers, and other therapies such as correcting valvular disease and controlling other systemic illnesses that might be contributing to their heart failure. Once all of this has been tried and the patient continues to have a weak, failing heart, poor prognosis, or severe symptoms, we will broach the topic of an extraordinary intervention, such as a ventricular assist device. These technologies are remarkable, and they're intended to help people when there are no other options. They can improve one's quality of life and survival, and buy time, and time at home, most importantly, for patients who may not otherwise survive or otherwise may have a very poor quality of life. The explosion in ventricular assist device use is partly attributable to market improvements in technology. The pump in the last few decades, and especially the last 10 to 15 years, has become much more miniaturized. It can fit into the chest. It's placed surgically through an open heart surgery, and it creates a parallel circulation to the heart to assist the weak and failing heart. By doing so, it improves blood flow to the body and improves congestion in the lungs. The combination of this gets rid of the shortness of breath and improves the patient energy. Over the course of months, the patient with improved circulation rebuilds their body, their muscle, regains their autonomy and quality of life. It's a really remarkable journey, and it is extraordinary in the right patients.
So, heart surgery is no small thing, but advances in medicine continue to lead to new treatment options, enhance patient outcomes, and in some cases, greatly reduced post-op recovery time. It is well documented that provided continuum of care for heart patients is vital to recovery. When it comes to transplant patients, can you tell us how the VCU Health Human Lease Transplant Center and Poly Heart Center collaborate to support patients through the recovery process?
Absolutely. Both centers are well integrated to create the heart transplant program. Members from both centers see patients early, walk patients and families through the expectations for a transplant evaluation, the wait time, the preoperative prep, and the postoperative recovery. There is a great focus on optimizing the patient condition, such as with nutrients and whatever rehabilitation is possible, so that they have a quick and speedy recovery from surgery and quickly regain their autonomy and symptom management and improvement. With all of this in mind, there are many people involved with the transplant program, including social workers, psychologists, pharmacists, cardiologists, surgeons, transplant coordinators, and there are also elements that many people wouldn't think of because they're not usually clinical, including financial coordinators, program managers, and our administrative staff. All of these people get to know the patients along their unique and extraordinary journey and are there to support patients and their families through the early and late processes. Also, in preparation for such a surgery, either transplant or VAD, we also have meetings with the psychologist and the palliative care team to ensure that patients are emotionally ready, have the support, and have made these decisions along with end-of-life decisions to ensure they're informed of all their options.
Thank you so much again for being with us today, Dr. Shah. Before we let you go, we have a tradition on the Patients Come First podcast to ask our guests a pair of fun personal questions. To keep things interesting, we have a list of 10 mystery questions. So why don't you choose two numbers between 1 and 10, and I'll ask you the corresponding questions.
All right, I'll choose 3 and 6.
Number 3, what is the best piece of advice you ever received, and why does it stick with you?
Wow. Best piece of advice professionally that I've ever received is from one of my early mentors who early in my career suggested that I not make any rash or immediate decisions on these complex patients and spend a little bit of time to marinate on what's going on so I can gain perspective of the entire clinical picture. And as a young physician, I, of course, brushed that information off, and only through lessons and time did I learn that this is critical for taking care of these complex patients, that no one can see the entire picture in a few clinic visits, and that it's important to have integrated collaborative care with all of the specialties I mentioned to really ensure we're making the right decisions for some of these patients, and we've thought through some of these complex plans.
Thank you for sharing that. And number 6, in the hypothetical scenario that you had one-time access to a time machine with limits, you can either travel 100 years into the past or 100 years into the future. Which direction do you choose and why?
I think I would love to travel 100 years into the past, and I think maybe I'm inclined for simpler times or a more certain outcome if I went there. I would love to see some of my friends and family's ancestors or parents or grandparents at a younger age, and I think I do appreciate sort of the more freewheeling times of the early 1900s before things got really serious.
That's a great answer. Thank you. And that will bring us to the close of another episode of the Virginia Hospital and Healthcare Association's Patients Come First podcast. If you like what you heard, please make sure to leave us a 5-star review on Apple Podcasts and subscribe so you know when new episodes are released. And we want to once again thank our guests for joining us today, so thank you.
Thank you very much, and I appreciate your time.